Thank you. So I would like to thank Ursula for the very kind invitation and for the opportunity to share with you our experience on OCT biomarkers for epiretinal membrane surgery. So advanced in OCT technology allowed us to characterize some new OCT biomarkers in many different retinal conditions, including the epiretinal membrane. Those biomarkers can be prognostic factors if they define the natural history of the disease, or they can be sometimes predictive factors when they tell us whether some treatment will result in favorable outcome or not. And some can be prognostic or predictive, and vice versa. So epiretinal membrane is pretty frequent. It's diagnosed by fundus evaluation and OCT evaluation, and the treatment depends in general in patient symptoms and OCT image. However, the functional and anatomical result is sometimes difficult to predict, and until recently we only had the age, the duration of the symptom, and the initial visual acuity to kind of predict the functional outcome. Fortunately, thanks to some incredible improvement in the OCT resolution in the last decade, as I said, some new OCT biomarkers have been characterized, and they will help us plan the surgery, predict surgical outcomes, and counsel better our patient in their decision to surgery. So there are many different OCT biomarkers. One is at the level of the membrane itself, and we'll call it elevated epiretinal membrane. There are 4 at the level of the inner retina, the ectopic inner foveal layer, the thickness of the retinal layer, the drill for disorganization of the retinal inner layer, and the macrocystic macular edema, also called macrocystic macular change. At the level of the outer retina, we have 2 different biomarkers. One is the integrity of the ellipsoid zone, and the other one will be the cotton ball sign. So the one at the level of the membrane itself is called the elevated epiretinal membrane. It will be detected by en face OCT, and so the detection of the separation between the surface of the retina and the epiretinal membrane will help us in some cases to grasp in a safer way the epiretinal membrane and reduce the number of attempts to grasp the membrane. And also it has been shown that this epiretinal membrane, when in contact with the inner retina, can infiltrate the retina and create some tissue damage. So probably when there's no or less there's more elevation or more separation, the inner part of the retina is probably less damaged. A paper published recently demonstrated actually that a better visual improvement was correlated with the surface of elevation of the membrane. So the more the separation you get between the membrane and the surface of the retina, and the better visual acuity you should get after surgery. A couple years ago, we published a paper on OCT staging scheme for epiretinal membrane. We had 4 stages. The first one was characterized by a normal anatomy of the fovea, so the retina looked pretty much normal. We just had a membrane on the surface and some bumpy things at the level of the inner retina, but the foveal architecture was, is normal. In the stage 2, you have an absence of the foveal pit, so the epiretinal membrane is actually lifting up the fovea and the pit disappears. The stage 3 is characterized by the presence of an ectopic inner foveal layer. So when you look at the cross-section here through the fovea, you can actually not see the fovea anymore because there's a new inner ectopic layer covering the fovea. And in the stage 4, it was characterized by a disruption between the different retinal layer. You cannot really tell exactly where the boundaries are between the different retinal layers. So looking back at the stage 3, we published a year ago another paper evaluating the impact of this ectopic inner foveal layer on the visual acuity, and we found that this ectopic layer was present in 50% of the cases and was significantly associated with a lower preoperative and postoperative visual acuity. That ectopic inner foveal layer persisted in more than 90% of the cases, and after surgery, even if the thickness of this ectopic layer was reduced over time, this was not changing the visual acuity. So this presence of ectopic inner foveal layer is a pretty bad biomarker. The stage 4, as I said before, is characterized by disrupted retinal layers. So there are multiple papers published recently on the disorganization of the retinal inner layer in epiretinal membrane or other retinal condition. That study published recently showed that between this case where there is no drill, meaning all the boundaries between the different retinal layers are clearly seen, so there is no disorganization, to that case where the severe drill, where all the different boundaries are very difficult to detect and see on the OCT cut, there's a big difference on the functional outcome after surgery. As you can see here, after surgery, when you have no drill, meaning this case, or moderate drill, in those cases, you have a pretty good functional recovery at 6 and 12 months. However, in the case with severe drill, you have almost no functional recovery at 6 months and 12 months. So there is another biomarker at the level of the inner layers. The inner nuclear layer thickness itself seems to be correlated with the level of metamorphopsia, and this seems to be correlated pre-operatively and post-operatively at 3 months. And this is probably related to some structural change of the inner retinal layer, where there is some distortion of the Muller cells leading to the metamorphopsia. The inner nuclear layer thickness is also correlated to the level of anisoconia before and after the surgery. So in most cases, the anisoconia corresponds to a macropsia in more than almost 90% of the case. And even if the surgery in those cases will improve the functional, the visual acuity, in most cases, at 3 months and 6 months, the level of anisoconia stays about the same. Macrocystic macular edema is another biomarker at the level of the inner retina. It's also called retrograde maculopathy, and it has been recently described in patients with advanced optic neuropathy. Those microcystic changes are almost exclusively located in the inner nuclear layer, and they are really well characterized or seen on the en-face OCT, where you see that they are not involving the fovea, and they are like macrocystic dot around the fovea. This corresponds to a non-vascular macular edema, as it is not leaking on the fluorescein angiogram, and this is very different from the classic cystoid macular edema you find in vascular conditions such as diabetic macular edema or macular edema in vein occlusion, where you have multiple cystoid changes, confluent cystoid changes in the different layers involving the fovea and leaking on the fluorescein angiogram. The macrocystic macular are non-vascular changes. They are, the pathophysiology stays uncertain, but it looks like, it's probably related to some dysfunction of the Muller cells leading to this non-vascular edema. We did a study a couple years ago, and we looked at all of our patients in the last year with idiopathic epiretinal membrane, and what we found is these macrocystic macular edema are present in 20% of the cases. However, the percentage is very different in patients with idiopathic epiretinal membrane and glaucoma or idiopathic epiretinal membrane with no glaucoma. As you can see here, this MME were present in 50% of the case with epiretinal membrane and glaucoma, and only 10% if they had no glaucoma. We also found that the presence of this macrocystic change were significantly increased with the level of the glaucoma, with the severity of the glaucoma. As you can see here, the odd ratio was much lower in mild or moderate glaucoma versus severe glaucoma, and was associated also with the stage of the severity of the epiretinal membrane, with a smaller odd ratio here than in stage 4 epiretinal membrane. So after surgery, in case with patient with no glaucoma, the number of microcystic changes decreased significantly at 1 month and 6 months. And in patient with epiretinal membrane and glaucoma, the number of microcystic change did not change significantly after surgery. So there is an evidence that ILM peeling may damage the macular cells, which are already compromised in patients with glaucoma. So before I was peeling the ILM in all the cases, but now I'm not peeling anymore in all cases, even more when the patient had epiretinal membrane and glaucoma. I think that the peeling of the ILM may not be only beneficial in those patients. The other thing I learned from that study was that the microcystic changes are not always only related to the ERM chronicity of severity. When you look at those patients here, you have one patient with advanced ERM, stage 3, with no glaucoma, vision is 20/80, and you can see those microcystic change, but there's also some thickening of the retinal thickness. There's a pretty advanced epiretinal membrane. In this case, the C-story change seems to be most likely related to the membrane itself, and the patient will most likely benefit from surgery. In this patient with moderate ERM and a severe glaucoma with 20/60 vision, you can see the microcystic change here. I mean, I don't think that the microcystic change are related to the severity or the chronicity and of the ERM, and I'm not sure if the patient would really benefit from surgery. Now let's take a look at the biomarkers of the outer retina. So the photoreceptors integrity of our ISOS disruption is a well-known factor, biomarker for functional recovery after surgery. As you can see here, there's a large disruption of the ISOS. However, you need to remember that in some cases, this disruption may improve after surgery, like in this case where at 1 month and 6 months after surgery, the disruption is almost completely gone. So it's a factor of bad prognosis in most of the cases, but sometimes the ISOS disruption in epiretinal membrane may improve after surgery. The cotton ball sign is another biomarker. We found cotton ball sign present in 20% of the epiretinal membrane cases, mostly in the stage 2 epiretinal membrane. And we think that this sign is actually part of the clinical spectrum, including foveal detachment and acquired vitelliform lesion. As you can see here, this is the cotton ball sign with the fuzzy aspect of the ellipsoid zone, which sometimes evolved to some foveal detachment and then the vitelliform lesion. So we think that it's the persistence of the traction which will make this case evolve to foveal detachment and vitelliform lesion. And what we found in our study is that the presence of cotton ball sign or foveal detachment and acquired vitelliform lesion was correlated with the pre-op and post-op visual acuity. However, this is controversial, as some other group did not find any impact on the function of this cotton ball sign. The last biomarkers is called the PROS length for photoreceptor outer segment length, and corresponds to the distance between the RPE and the ellipsoid. This is the PROS length, and seems to be strongly correlated with the visual acuity before the surgery and after the surgery. So in summary, there are several OCT biomarkers, one at the level of the epiretinal membrane. So the more separation you have between the epiretinal membrane and the inner part of the retina, and probably the better visual acuity the patient will recover. The ectopic the ectopic foveal nuclear layer, which is correlated with the worse functional recovery. The inner nuclear layer thickness correlated with the level of metamorphopsia and anisoconia. The disorganization of these different layers will most likely lead to a limited functional recovery. The macrocystic macular edema, just remember that it's not always correlated to or related to the severity of the epiretinal membrane, but can be related to some optic nerve problems. The ISOS disruption, also correlated with the worst visual acuity recovery. The cotton ball sign, controversial, and the path length seems to be correlated with the worst visual acuity. So I think that those biomarkers are a critical piece of information to decide for surgery. However, I strongly recommend to keep in mind that the clinical evaluation is still very relevant, and the complaint of the patient with the metamorphopsia, the duration of the symptoms are also very important in the decision-making process for vitrectomy. Thank you very much.